Hey Medical Squad, welcome back to my channel. Today I'll be discussing diabetes insipidus versus primary polyuria. I also compiled 9 high-yield slides to get you free points on test day. I also have the perfect mnemonics to help you distinguish between them. Hopefully by the end of the video, you'll be able to answer the practice questions I have at the end. Let's get started. Let's begin with diabetes insipidus or DI. DI is a rare disorder that causes the body to make too much urine. So I want you guys to remember for DI, that stands for dilute urine. So the DI, dilute urine. So we have to understand urine osmolality. Remember the number 300. 300. So if it's less than 300, that means that is dilute urine. And if it's greater than 300, that means that it's a concentrated urine. So what does dilute urine or concentrated urine means? So dilute urine means there's little solute in the urine, so that is clear P, so it's less concentrated and more water. And concentrated urine means there's more solute in the urine, that means it's yellow P, that means there's more solutes in the urine, so it's concentrated. So remember the number 300. When you have your labs and you see the urine that's less than 300, that means it's dilute urine, and if it's greater than 300, that means it's concentrated urine. What are the causes of polyuria, increased urination, and polydipsia, increase in thirst? The three main differential diagnoses I want you to think about is 1. Central diabetes insipidus, ADH deficiency, 2. Nephrogenic diabetes insipidus, ADH resistance, and lastly, primary polydipsia. Now let's get started with the good stuff. Central diabetes insipidus, also known as ADH deficiency. So whenever I think about central, I think about the central nervous system, okay? So the central nervous system is composed of the brain and spinal cord. So I know in central DI, something is affected. The brain is infected somehow. Remember that the hypothalamus makes majority of our hormones. Number 1, ADH comes from the posterior pituitary gland, not the anterior. Number 2, let's break down ADH. ADH stands for antidiuretic hormone. Again, antidiuretic hormone. So that means that it's not a diuretic. If you know different types of diuretics, we have loop diuretics, we have thiazide diuretics, and the purpose of these diuretics is to remove excess fluid, right? If we have excess fluid, like with congestive heart failure, nephrotic syndromes, we want to remove the excess fluid. So the purpose of ADH is to hold water inside of the body. That's the purpose, to hold water inside of the body. So remember the H is for holding water inside of the body. Lastly, in central diabetes insipidus, we do not have ADH. ADH is not there because the posterior pituitary gland is not making it. So if we don't have ADH, right, and the purpose is to hold water, right? The purpose is to hold water inside of the body because we don't have ADH anymore because we're deficient. So we are what? Losing. We are losing water. So we have increase in dilute urine. Now I want you to pay close attention to the red letters on the board. The red letters will help you differentiate between central versus nephrogenic DI. Remember, your patient will come in and complain of polyuria and polydipsia. No, those won't be their exact words. Their exact words would be an increase in urination and increase in thirst. And remember your top 3 differential diagnoses? What are they? Yes, central DI, nephrogenic, and also primary polydipsia. The first test you would want to do is a water deprivation test. This test, you will tell your patient to restrict all fluids. So no water, no juice, no coffee for a certain amount of hours. In an individual who does not have diabetes insipidus, the normal physiological response is to increase the ADH receptors. Because if you're not drinking anything, the body is going to think that you are going to become dehydrated. And the body doesn't want that. So it increases the ADH to hold on to the water that it already has, not remove it because you'll become dehydrated. So if the body holds on to the ADH, that means your urine would be concentrated, because if the body is holding on to the ADH, then it's holding on to the water, and all of the solutes, what is like sodium, chloride, all of that is going to be inside the urine, and that is going to concentrate their urine. In a patient who has diabetes insipidus, They don't have ADH. So the urine will still be what? Dilute. So if you do a water deprivation test and the urine is still dilute, that means there is no ADH. So now, next test you have to do is the desmopressin test. The desmopressin is an analog to ADH. So it's giving the body something that it's deficient in. It's deficient in ADH. Let me give you a couple of examples. If a patient is iron deficient, what will you give them? Ferrous sulfate. You're going to replace the iron with a pill. If a patient has vitamin D deficiency, you're going to give them what? You're going to give them vitamin D to replace it. If a patient doesn't have insulin in a diabetic type 1, what are you going to give the patient? You're going to give the patient insulin to replace what they don't have. So that is what the effect of desmopressin. Desmopressin is basically putting ADH inside of the circulation. So in a patient with central DI, they're ADH deficiency. So what would you expect when you give them what they don't have? You will see a change in the urine osmolality. Okay? So let me explain this. You have to understand this. This is where the questions will get you. So central diabetes insipidus, remember the C. We did the water deprivation test. Remember, our lucky number is 300. 150 is dilute or concentrated. Remember, anything less than 300 is dilute, and anything greater than 300 is concentrated. In this patient, when we did the water deprivation test, it is still what? Dilute, because it's less than 300. Now we give the patient the desmopressin, something that the body is missing, right? In central DI. We give them the desmopressin and you see the change. You see the change to 150 to 450. That means there's a change in the concentration. So whenever you see central diabetes insipidus, the C stands for change. Change in urine osmolality, okay? So you have to see a dilute concentration to a concentrated concentration. Next, nephrogenic diabetes insipidus, also known as ADH resistance, okay? Remember the other name for the disease. Again, we're doing the same thing. The patient would come in with polyuria or polydipsia, increased urination, increase in what? Thirst. The initial test is the water deprivation test. You tell your patient to restrict fluids. The goal is to what? Increase the concentration. But in a patient with nephrogenic diabetes insipidus, the answer for the water deprivation test will always be dilute, just like for central DI. What is next? The next thing for us to do is the desmopressin. We have to give our patient desmopressin because we want to understand what is going on. Why isn't the body concentrating the urine once we restrict fluid? We give the desmopressin, right? There is no change in your osmolality, or we can say minimal change because, there could be a variant. So there is no change. There's a slight change in the urine osmolality. Remember, nephrogenic DI means there is no change or minimal change, okay? Let me give you the example. You do the water deprivation test and the concentration is 150. Is that dilute or is that concentrated? Remember, our lucky number is 300. Because it's less than 300, that is dilute. If it's greater than 300, then that is what? Concentrated. So now we give the patient desmopressin. And remember, the desmopressin is an ADH analog. So you're giving the patient what they're missing, right? If they don't have it. But you give the patient desmopressin, and what is the concentration? Is it dilute or is it concentrated? This is still dilute. So there is no change from the 150 to the 155. That means there is something going on with what? The kidneys. The kidneys are not responding to the ADH. It's not the brain. If it was the brain's problem, then it will be central. But because you're giving the patient desmopressin and it's not concentrating the urine, even with the ADH inside of the circulation, that means the kidneys now are not responding, okay? So remember, nephrogenic, no change in urine osmolality. So remember, that is a slight change. You see, 150 to 155. Come on, you guys, that's not a major change. So remember, nephrogenic, no change in urine osmolality. That means the urine will still be dilute. Now on to the last section, primary polydipsia. Again, if you are still having difficulties differentiating between central versus nephrogenic diabetes insipidus, please go back to that section. Again, we will start with water deprivation. We are telling our patients no water, no coffee, no Red Bull, no Celsius, nothing. You are restricting fluid. And the natural response, again, is to increase the ADH receptors and to concentrate the urine. And we see just that. With the water deprivation test, the result is concentrated urine. This means the central part is working, which is the brain, and the nephro part is working as well, which are the kidneys. Remember, the brain releases ADH from the posterior pituitary. It then goes to the kidneys, and the kidneys have to receive the ADH in order to concentrate the urine. Because remember, the ADH holds on to what? The H2O. Example, if this is the urine has water, which is blue, and it has other solutes, which are the green, the yellow, all of that. So now, if ADH is properly working, then ADH is removing all of the water. So now if you remove all of the water and you're only leaving the solutes, if you guys see where I'm going with this, that means there's going to be increased concentration in the urine, right? Because we took all the water. That means the ADH is working. This is primary polydipsia because nothing is wrong with their receptors. Nothing is wrong with the brain. There's nothing wrong with the central or nephrogenic part. The patient is just drinking excess amount of water, as you see here. The patient is drinking excess amount of water, but the body is working normally. The real question is, do we have to do a desmopressin test? And the answer is technically no, but you can still do it just to confirm your diagnosis. We know that the ADH is working properly and the body is producing it and the kidneys are receiving it because the urine was concentrated. So let's think about it. We give the patient desmopressin. We should see no change in the urine osmolality. Why? Because the body already has it. You're just giving the body excess ADH and it already has it inside the body. So with primary polydipsia, the water deprivation test, you tell the patient to restrict the fluid, it's 600. And is that concentrated or dilute? You guys tell me. 300 is our lucky number. Less than 300 is what? Dilute. Greater is concentrated. So we know with the water deprivation, our urine is concentrated. We give the patient desmopressin and it's still concentrated, which means ADH is working properly. We can even put 700. We can even put 800 because we know that the body is able to respond to the ADH. When you're thinking about a patient with primary polydipsia, think about a patient who is drinking a lot of water. If you're drinking a lot of water, of course your urine is going to be dilute because you're drinking a lot, you're peeing a lot, and you're removing the excess water, okay? So you can think about this as a psych patient. A psychiatric patient who's drinking a lot of water, who has anxiety, who has psychiatric conditions, who are taking any antipsychotics, who is increasing their water intake, think about primary polydipsia. I also want you guys to look at the urine osmolality. Whenever you have labs on your world, on your exam, I want you to look at this. If it's less than 100, I want you to think of primary polydipsia. There is no way why your urine should be that dilute. It should be like malnutrition or something. But remember, if you see this key less than 100, so you see 99, 85, think about primary polydipsia. And that concludes our section on the top 3 differential diagnoses of polyuria and polydipsia. Now let's do some questions. Question 1 out of 3. A 44-year-old woman comes to the office due to excess thirst and urination. Right now, we can give 1, 2, 3 differential diagnoses for excess thirst and urination. We have central DI, we have nephro DI, and we also have primary polydipsia. Okay? Right now, we can go straight into our answer choices to see, but let's finish the vignette. She has to get up several times during the night to urinate. 2 months ago, she was diagnosed with type 2 diabetes mellitus, which she is managing with diet and exercise. Blood pressure is 134/78, pulse is 88, BMI is 32, which is elevated. The remainder of the physical examination is normal. Okay. Laboratory results are as follows. So we're looking at the sodium. We can look at that. We also can look at the serum osmolality and the urine osmolality. But because we're learning about polyuria and polydipsia, our main concern is urine osmolality. It is 180, right? So remember, our lucky number is 300. Is that less or greater than 300? 180 is less, right? So that means the urine is dilute. When we think about dilute urine, we're thinking about central and nephrogenic DI, okay? So let's look at our answer choices. SIADH, no. Hyperglycemia, no. Hypothyroidism, no. Diabetes insipidus, is that on our list? Yes. And hyperthyroidism, no. So let's think about SIADH. Let's understand why these answer choices are wrong and the way that I'm thinking about it. So for SIADH, this is excess ADH. So with excess ADH, we would see the normal response of ADH, which would be what? Concentrated urine. The urine is not concentrated, so that is wrong. Hyperglycemia, we do see an excess of glucose because the normal is 100. But again, it says that she manages it with diet and exercise. And it's not that elevated. And also, if we had her HbA1c, which when we HbA1c percent, we don't have that here. But that's not our main concern. Hypothyroidism. So with hypothyroidism, we would see a decrease in heart rate. And hyperthyroidism, we see an increase in heart rate, which is tachycardia. And this is bradycardia. The heart rate here is 88, and that is in normal range because normal is 60 to 100. So we're in between diabetes insipidus and we're between hyperglycemia. The best choice to me, because of the excess thirst and urination, that is key to what? These 3 differential diagnoses. So the best answer here is diabetes insipidus. Question 2, part 1. For this question, I want you to do this on your own. Highlight the important details and also write down your differential diagnosis and your lucky number. I'll be back in 10 to 15 seconds and I'll show you how I approach this question. Hey MedSquad, hopefully you're not upset, but yes, this question has 2 correct answers. Why? Because in order for you to have a definitive diagnosis for your patient, for this patient, you cannot depend only on the water deprivation test. You need the desmopressin test, the ADH analog test. So you should be between 2 answer choices. So let's get started. If you were between 2 answers, you are headed in the right direction. So let's get started. A 30-year-old woman comes to the physician complaining of significant increase in her daily urine volume and intense thirst. What are your 3 differential diagnoses? Write it down. The symptoms started a few weeks ago. She has to get up frequently at night to urinate and drink fluids. She has no other medical problems. The patient does not use tobacco, alcohol, or illicit drugs and has no known allergies. Her mother developed diabetes mellitus as an adolescent. Temperature is 98 Fahrenheit, blood pressure is 110/70, pulse 75, respiration 15, fasting serum laboratory results are as follows. You can highlight the sodium, also the serum osmolality and the urine osmolality. Those are your big guys, okay? After 6 hours of water deprivation, laboratory results are as follows. So again, our osmolality are our big guys, okay? So this is fasting. We look at the urine osmolality and it's 126. Is that less or more than 300? That is less, right? So we know that this is dilute urine. Now, what is our initial test? Remember, our initial test is to do a water deprivation test, and here it is. So now we have our water deprivation test, and the patient was restricted from fluids. So we look at our urine osmolality, and guess what? It is still diluted, right? Because if we see our 300, we look at our urine osmolality, and it's still dilute. So we're in between what two things? We have our three. We have central, we have nephro, DIs, and also we have the primary polydipsia. But guys, remember for primary polydipsia, the urine was concentrated because ADH is working. So we're in between what? Central and nephrogenic diabetes insipidus. So your answer should be A and C. Again, there is no way for you to tell if it's nephro or central without the ADH analog. Okay? Remember that. Question 2, part 2, same question. Now we have to figure out if this is central or nephrogenic diabetes insipidus. Now it says 1 hour after the subcutaneous administration of arginine vasopressin. This is another word for ADH, guys. ADH, vasopressin is the same thing. The urine osmolality is 395 milliosmoles per kilogram. Which of the following is the most appropriate treatment for this patient? Okay, guys, I'm going to pause. What do you think the answer is? And what is your definitive diagnosis for this patient? I'm back now. Now let's get back to business. Remember, we did our water deprivation test. This is our first test, and our subcutaneous administration of ADH, arginine vasopressin, is our second test. Remember, our initial test is always the water deprivation test. We did that, and our urine osmolality is 132. Next, we did the ADH analog. And it says the urine osmolality, remember the urine osmolality is the big guy. We always have to pay attention to that. Is now 395 milliosmoles per kilogram, right? So what is this telling you? Did the osmolality change, or did it stay the same, or it's no change? Remember, the no for nephro, the central for change. And what happened? It went from 132 to 395. So we know that this is what? A change. So this is a central diabetes insipidus. You gave the patient ADH, and the urine was able to do its normal job, which is to concentrate the urine. So now we know our definitive diagnosis. Our definitive diagnosis is central diabetes insipidus. This is our definitive diagnosis. For question 2, part 1, we were in between nephrogenic and also central. But now that we have the desmopressin, the ADH, we can now differentiate between the two. Because there was a change between 132 for our initial test and 395, 132, which is dilute, and 395, which is what? Greater than 300. So we know our urine went from dilute to concentrated. That means that this is a central diabetes insipidus. And what is the drug that you would want to give to help your patient out? You don't want your patient to continue to have increased urination, increase in what? Thirst. You'll want to give them what? desmopressin because this is ADH. You are giving the patient what the body needs. The body is deficient in ADH, so you're giving them what they're deficient in. So let's go over. So what is the appropriate treatment for this patient? Water deprivation test? No, that's not a treatment. This is how you can differentiate between the differential diagnosis. Change in diabetic medication. The patient's glucose is 90. I don't think that's important. Refer to endocrinologist, guys. Definitely the wrong answer. You need to help and treat your patient. You can if you can't figure it out, but that's never the right answer. MRI of the brain? No, because that's not going to help you, right? This is not telling you anything. The water deprivation test and the ADH analog is basically giving you the proper workup to figure out what is going on with the patient. You don't need a brain MRI to understand the difference between central and nephro. A thiazide diuretic, no, you would not want to give this patient a thiazide diuretic. That would increase the urination and it will also increase the patient's dehydration. Okay? So let's clear this up and hopefully you guys understand why this is central diabetes insipidus. Remember, guys, use your mnemonics. Remember nephro for no change. Central change. Whenever you see DI, if DI is in the name, then the first test will be dilute. Just like this, dilute. This concludes diabetes insipidus and the main differential diagnosis. If you have any questions, please reach out to me. If I said anything incorrectly, let me know. Drop it down in the comments. And if you did like this video, please like, comment, and subscribe. Share it to a friend. And have a great rest of your day. And remember, always go with your first choice.